a root abrasion with no gingival recession at all, so it will be restored by means of the composite restoration. We have loss of papilla. We will make also a radiograft, but there is also some loss of bone. And so what we would like to make is not only a better coverage and a better quality of the keratinized tissue covering the canine, but also, if we can, a slightly improve of the filling by the interdental papilla by adding connective tissue graft on both the root surface and in the interdental area, where we would like to make like a tunnelization and coronal advancement of the whole papillary complex. I absolutely believe that the only indication we have now for the tunnel technique is to improve the position of the papilla in those situations in which we have loss of attachment, loss of papilla, and loss of bone. If the papilla is completely healthy, it does not make sense to tunnelize the papilla to coronally advance the flap, because the flap is coronally advanced and stabilized at the level of the surgical papilla. So we will make obviously not the tunnel technique as it is, but a modification of the tunnel technique with true trapezoidal incision distal to the canine and mesial to the lateral. We were going to tunnelize this papilla from the inside in order to make it as much as coronal as possible. And then we will use some composite restoration in order to suture the papillary complex in a more coronal position, with the attempt to minimize the shrinkage of the papillary complex by adding a connective tissue graft in the root and in the interdental soft tissue. So now we make anesthesia. Anesthesia is always made far from the area of the pedicle. So you see I go to the homologous contralateral tooth at the level of the central incisors. I bend the needle and with a very slow injection, I will put anesthetic in the area of the surgery. As much I inject anesthetic, I introduce my needle more in order to bring anesthetic exactly in the area between the lateral and the canine. I will do the same starting from the 5 towards the canine. Now I gently remove the needle in the same direction I inserted, and now I'm making anesthesia from 5 to 3. Again, at the level of the 5. Bene?
Sì. Voglio vedere la suoneria.
Vuoi vedere?
Tiro io la suoneria.
Okay. Now we make some anesthesia also at the level of the palate. So there won't be any pain when we are going to harvest the connective tissue graft from the palate. Also, when you make anesthesia in the palate, you have to check from the hard palate, that is that one you don't move with the probe, with the soft palate. You see here, you can move the palate, and anesthesia has to be made in the soft palate, so reduce dietro, apre Massimo, so to reduce as much as possible. Ti sei? This is just, ma la rifacciamo dopo. This is just a small amount of anesthesia that is used, so when I will back to the palate, I will complete it, but with no more pain and discomfort for the patient during the surgical procedure. Okay, now we are making a radiograph of the tooth, so you will not see anything for a while. Chiudi. So now, lasciami, dopo te lo do. We prepare the two vertical releasing incision for the treatment of the gingival recession on the canine. Horizontal and vertical. And the same thing is done at the level of the lateral. Horizontal and vertical. This incision will be extended minimally in alveolar mucosa. La fisiologica che ce l'hai in mano? This is the elevation of the first split thickness papilla. Now I go mesial. And this is the elevation of a second surgical papilla. Now, vieni qua. I will extend a bit more in lining mucosa, the minimum I can, the vertical release incision, so to make a very deep incision, parallel to the bone, parallel to the bone. And the same is done mesial along the vertical releasing incision, parallel to the bone, parallel to the bone. Now it's time to elevate full thickness the keratinized tissue apical to each gingival recession by inserting it the periosteum elevator This is some remnants of the regenerative procedure which was made more than 1 year ago. Now I'm trying to elevate full thickness the base of the anatomic papilla, getting inside the keratinized tissue from one side and to the other side. I will look for the bone now. I try to get access to the soft tissue apical. First of all, I will use the vertical release incision, and then I will start the tunnelization of the interincisors papilla. As much as I get inside the interincisors papilla, I reduce the dimension of periosteum elevator. I have to be very, very careful because this is really very, very thin, and I have to get it free from muscles, no? With the blind incision, making the papilla free from muscles. On one side, and also on the other side, un pochino più verso, Vedi tu, sì? Così? I need to get access to the lining mucosa, apical on one side, to the lining mucosa, apical on the other side. And now I should start to move this tissue by getting access in the inner aspect one side, mi ispiri lì per favore, sempre qui. I have to qui. I have to isolate from the deep and superficial tissue the whole papillary complex, and at the same time start to move it very, very carefully in coronal direction. Tirare dentro. Now I try to get in the more palatal aspect, tirarmi la papilla, fisiologica sulla papilla, qui, fisiologica, lamina. And as much as I do this, I have to check for the mobility also. Of the tissue in coronal direction. Now with the probe, I want to check where is sonda. If there is any interference from the base of this papilla to the other. There's still some it's so thin that the only instrument I can use in this area obviously is the probe to force in more corner as possible the position of the interdental tissue. Qui, mi serve lì. Now I take a knife, very small knife, because I want to get free from any spirale fisiologica. No. And again, I come back. Force a bit. I use the bigger area to push and reach. Aperto un pochino. The palatal aspect. You see that now the papilla is a bit more corner than it was before. What I have to improve is the line angle of the mesial aspect of the canine. This area. And so I will use my knife, Tini, to get access to this inner aspect in order to get rid of some muscle still present in the most apical aspect. Now here it's free. Also free here. You see that now I can push the papilla in corner direction while I will be able to make both the soft tissue margin covering the gingival recession and placing the papilla in the most corner position as possible, and in this position they will be maintained by the connective tissue graft. Now I'm working on this side. In order to see that everything is completely free. Respirare. One. What I have to reach, obviously, is the same level for the interdental papilla of the homologous teeth. And now I think it's in a good position. It's even more corner with respect to the papilla between the lateral and central. And in this position, I will suture it. But now I have to add the connective tissue graft. May I have the knife, please? Bene. Ok. Qui? Perché al punto di contatto non ci posso arrivare perché è il punto di contatto che è spostato troppo coronale, giusto o no? Dai. I reach the palatal aspect. You see that when I move my instrument, I can also improve the palatal aspect of this papilla. And the root is completely coverable now with the soft tissue. Okay, now it's time to make root planing, both at the level of the canine. So I move back the papilla away. I isolate it with my finger. You see that there is an abrasion area here. Posso avere una picture? No, uno Tienimi il labbro. Qui. Il labbro. Isolate the root.
Tengo così? Tieni, aspetta.
Bene? Bene? Qui? Bene? Qui? Finita? Toglimi quella garda che non serve più a niente, ok. Qui è meglio? Meglio qui? No? Verso di me. Anche qui? Allora, aspetta che faccio un po' l'anestesia in alto. Lascia a me. I don't make anesthesia in the pedicle, but I make it from the inner aspect because there is some pain during the root planing procedure. So now we make some root planing on the lateral first. Apri bene. Apri bene. Meglio qui? Now I have to move the papilla away. Uno scolopiostre piccolo. Not to traumatize it during the root planing procedure of the interproximal area. Fermo. Fisiologica.
Cosa faccio da tenerla?
Okay, now we do the same thing on the mesial aspect of the cannon because it's very dangerous because the keratinized tissue is really minimum. Okay, yeah. Now ADTA. Okay. Now we will prepare the amelogenins that in this situation are there. Bene ora il dolore? Quando non gratto va bene, vero?
Sì.
And we also have to evaluate how much connective tissue graft we have to take. It's about 20 millimeters to go from one side to the other side below the coronally advanced soft tissue, papillary soft tissue. We still have to make the desepithelialization of the papilla. Mhm. C'è un bel aiuto queste trapezoidali però, sai, per poter accedere senza traumatizzare. Se no... Okay, now we rinse a lot. Okay, now we desepithelize the papilla and then we apply Endogen during the time it takes for us to take the connective tissue graft. Apre bene? First of all, say, we sign where to accomplish the desepithelialization. Then we complete it with the scissors, and the same is done mesial. Okay, now we take some Endogen and we use it both on the root and on the subgingival portion of it. Now we go to the most posterior area. Spirare un po' più vestibolare appena. Apri bene bene. We complete anesthesia at the level of the soft palate. We have to take 20 millimeters of free gingival graft that will be then desepithelized. Bene adesso? Antonio? Now that we fix the distal vertical release incision, we check for the last time that we need 20, and then we make the second. Male? We calibrate the thickness mesial, and we try to give the same thickness from mesial to distal. Katia? Apre grande, grande. Now I deep the vertical release incision in order to open also the distal aspect like the mesial one. Now I connect the distal vertical release incision with the mesial. Make it deeper and deeper until the graft. Va bene. Perché non mi aspiri Katia sulla linea? Dov'è la linea? Qui?
Fatemi anch'io.
Non mi aspiri dove serve qui. Now we take some collagen substitute. And we put some material in order to stabilize the blood clot. And we make the suture. 5. During apri bene. We take some gauze. We go apical and distal.
Chiudi gli occhi.
We make a mattress horizontal. We turn around the 7.
Apri, apri.
Ne vai da qua? Vai. Apra bene. Sì, sì. Apra bene, bene. Now we close the knot in the most distal and apical to block any bleeding. Apra bene. Dai, un po' di soluzione. Dai.
Apri un po'.
Now we do the second mattress suture, more mesial. This is around the molar tooth, first molar. And then we close, and normally after 2 sutures, bleeding is completely under control. You see that the distal knot is always placed. Il Lugurò non l'ha neanche preso. Apri bene. Apri bene, via con la lingua un attimo. Okay, now the area is completely under control. We leave some gauze here, and we go to prepare our connective tissue graft that, as you can see, is a bit thicker than what we are used to doing for teeth, because in this case, obviously, we want to improve also the position of the papilla. You see that the inner aspect of the graft is white, so we don't have to make too much in the inner aspect, and now we are going to remove the epithelium, which is quite thick in this patient, especially smokers. I remove some glandular tissue from the inner aspect. And as always, some epithelium in the most coronal. Area, so that a very good quality of connective tissue is left. You see that the thickness in the mean portion was left greater because it's the area of the papilla, while the area peripheral are very, very thin because they correspond to the area where the papilla will be covered. And you see that this is really good quality of connective tissue. Now we go to the patient back. We have to stabilize the connective tissue graft at the base of the anatomic desepithelialized papilla. Solo mesiale distale, non lei. Lì lo facciamo dopo. You see? Vado? So this is the dimension. We have to place the graft from one side and taken on the other side until it will be displaced. Sì, dopo lo facciamo. At the base of the anatomic desepithelialized papilla. Ok, abbiamo smesso di aspirare completamente, non so. Sì. Okay, now I fix the graft at the distal aspect of the canal. Apra appena. Surgical papilla, anatomic papilla. No, non è il filo, basta solo che mi tieni su questo così. Si vedono?
Chiuso? La pincetta è chiusa o aperta?
No, così va bene.
È aspirato.
Non importa, aspirare dove? Fix then, no, ora si fisiologica. I'm fixing now the graft at the base of the desepithelialized anatomic papilla on one side. Lascia. Then I go to the other side. I take the graft from inside. Aspirare bene. Un pezzo di filo, vero? Sollevami la papilla un attimo. Now it's important to close the contact point by means of some composite restoration. And evaluate where is the positioning of the connective tissue graft that should be sutured together with the papilla tissue around the one occlusal stop that is placed with the composite in the occlusal aspect. So, sai cosa? Potevo farlo un po' più corto, veniva più teso. Tieni qua. I prefer to give this suture back because if I reduce the length of the graft and I pull it a bit more in this way, it keeps more tension. Now, may I suture back?
La papilla. Tiene questo. Tengo la papilla.
Via, via.
Lascia.
Ho 1000 peli. I will look if it is still possible to improve also the positioning of the graft at the level of the canine. So it's always better to take shorter graft in this case. It's different from teeth because we have created a sort of wall technique. You see, if as much as I pull this, you see, as much as already the papilla goes corner. Nice, eh? So I removed some more graft from this area. You see there? Then give me the suture back. I have to create as much as tension as possible with my connective tissue graft from the mesial to the distal papilla. Okay? Now I suture it back with more tension at the base of the anatomic disepitalized papilla. Tienimela su un attimo. Until I can see that really the graft, apri un pochino, is placed.
Si vede?
Lascia pure. Okay, now that the graft is placed in the right position on both teeth, and also the papilla is much more passively positioned in the same position, I will take some etching. Okay, now there is to place, lascia me, the surgical papilla in position. Surgical anatomic papilla in position, surgical anatomic papilla in position, and then we have to make the suture. Now I will make some etching in this area. Vieni qua.
Apri.
Solo vedere. Okay, now rinse it. We take a gauze to protect the flap during drying. Mi dai un po' di adesivo.
Apri un po'. Sulla testa un po'.
Fermo, non chiudere. Vai con la...
Aria.
Vai. We use some flow to close the contact point.
Cosa?
Dai. Dai, sei zero. First, see. Now, first of all, we close the surgical above the anatomic papilla and the adjacent teeth. Era meglio suturare prima le papille che mettirono già un po' più coronali anche loro, no? E poi per ultimo quello lì, giusto? Okay, now we close surgical above anatomic papilla with a sling suture at the adjacent teeth. Ci sei? Surgical anatomic papilla. Palatal papilla. We turn around the two premolar teeth. Mi fai vedere un po' di più quest'area qui? È occlusale o palatale? Palatale, ok. È palatale, sì. We make perforation of the papilla between 4 and 5 in order just to have an anchorage, and then guarda qua.
Dice a me?
Sì, guarda com'è. Questa che dovrebbe mettersi qua. Ok, fisiologica. And now we close surgical above anatomic papilla.
Così lo.
Now we create the compression surgical above anatomic papilla in the final position, the most coronal position as possible. Now we close the same papilla between the lateral and the central, surgical,
Tenete mamma.
anatomic, palatal. Apra bene. We get anchorage to the interincisors papilla now. Again, perforation. And closure. Again, we want to place this papilla right, above the anatomic desepithelialized papilla in the most coronal position as possible in order to cover in excess also the gingival recession of the lateral. And now there is the last suture, which is intended to take in one shot. Me ne dai una nuova? We can take it occlusal. Now we have to make a one-shot perforation at the base of the papilla in order to take also the connective tissue, one shot until you reach the palatal aspect. Apre bene. Ora devo farla passare da sopra, poi di nuovo sotto, giusto?
Io che do-
Now we pass below the contact point. We go palatal again in this way, giusto? So we keep anchorage to the contact point, and now we go from the palatal to the buccal, okay? We put the papilla in the right position. We make a perforation, one shot at the base of the papilla, and we go back at the buccal. We make another tour here, giusto?
La chiusura la facciamo vedere da...
And now I close it. First of all, I will show you the close. No, prima la facciamo così e poi dall'altro, ok? And this is supposed to shift the papilla in a more coronal position as possible.
Giusta?
Mhm. Quindi cambiarla no, Ok. Now that
Sono...
everything is stable, we go back to the buccal surface and we complete the closure at the level of the vertical release incision. Now we have to close completely the vertical release incision. Vado. At the level of the most apical extension here, without getting into the sulcus. Intramural sutures. Che ora è?
Così un altro.
Che nocciole, eh? We want to minimize the exposure of the blood and close by primary intention. Now we do the same on the other side. These are all intramural sutures from the keratinized tissue of the flap to the keratinized tissue of the adjacent teeth to provide complete closure at the level of the vertical release incision. Now let me check also, togli un attimo l'alcribook, the most apical extension of the vertical release incision that should be closed here. And the same should be done distal. No, it's okay. Now we can see the final outcome of this long story. You see that the position of the papilla between the lateral canine is even more conal than the papilla of the central and lateral, so we currently advance at least 3-4 millimeters, also the papilla, and the possibility for the papilla to remain in such a position depends on the stability of the connective tissue graft, which is immediately below. And so we were able in one surgery to improve both the papilla and to cover the two roots. As you can see, it's a quite difficult surgery, much more than treatment of gingival recession only. But it's a new and let's say the only way we know now to surgically improve the position of the papilla, which was lost to periodontal disease and periodontal treatment.